What if the exact same virus that causes a skyrocketing, highly stigmatized cancer is also, counterintuitively, the exact thing that gives patients their best chance of surviving it?
Yeah, it really sounds impossible when you first hear it.
Right. But today we are opening up a medical document that is, frankly, completely rewriting the rules of modern oncology. So welcome to today's deep dive.
I'm glad to be here.
We are looking at the ESMO Clinical Practice Guidelines on Anal Cancer. And it's this incredibly comprehensive, highly specific roadmap detailing how the global medical community is battling a disease that is silently becoming much more common.
And our mission today is to really decode a massive paradigm shift in how we treat it.
Okay, let's unpack this because we are watching the field move away from this blunt, surgical, cut it out mentality and toward, this incredibly elegant strategy of targeted organ preservation and literally hijacking the body's own immune system.
It really is a fascinating convergence of disciplines.
Yeah.
We aren't just looking at the mechanics of shrinking a tumor anymore. These guidelines show how virology, advanced imaging, and honestly, a deep respect for human quality of life have all come together to change the standard of care.
Absolutely. So whether you are a medical professional trying to catch up on the latest guidelines or you are just an insanely curious learner, this deep dive is going to give you a masterclass in how modern medicine adapts to complex challenges.
Without overwhelming you with just a wall of medical jargon.
Exactly. We're going to do it by looking under the hood at the actual biology. So we need to start with why this specific document is demanding so much urgent attention from the medical community right now.
Right, because technically, anal cancer is considered a rare disease.
Yeah, it accounts for less than 1% of all new cancer diagnoses.
But there is a very alarming trend hidden behind that low percentage.
The incidence of this cancer in the United States has more than doubled over the last 40 years.
Yes, the numbers are climbing steadily. And the most common histological subtype we're dealing with here is called squamous cell carcinoma of the anus, or SCCA.
SCCA. Got it.
But, the real tragedy underlying that rising statistic isn't just the frequency of the disease, it's the massive delay in diagnosis.
Which is just heartbreaking. When patients first experience the primary symptom, which is rectal bleeding, they almost universally attribute it to a very common, entirely benign condition.
Right, they assume it's just hemorrhoids.
They just brush it off. It's like ignoring the check engine light on your dashboard because you assume it's just a loose gas cap. But by the time you actually look under the hood, the engine is already on fire.
That's a great way to put it. Patients ignore it, and frankly, general practitioners sometimes dismiss it too.
Which brings up a huge question for me. If the incidence is rising so sharply, why aren't doctors catching it earlier? I mean, the guidelines mention a simple, low-cost tool called the digital anorectal examination.
Yes, a very standard tool.
Why isn't that being utilized more proactively the second a patient mentions bleeding?
Well, it comes down to human nature colliding with clinical hesitation. There is immense stigma and discomfort associated with this area of the body.
Right, no one wants to talk about it.
Exactly. And because bleeding is so statistically likely to just be hemorrhoids, both the patient and sometimes the physician are eager to accept that easy answer.
So they avoid the exam.
Yeah. The digital rectal exam is a fundamental diagnostic tool, but it frequently gets delayed until the symptoms like severe pain or a noticeable mass become impossible to ignore.
And unfortunately, by that point, the cancer has had months to establish itself.
Precisely.
And what's actually driving this underlying rise in the first place, the source material points to a viral culprit.
Yes, 80 to 85% of these patients have the human papillomavirus.
Specifically HPV subtypes 16 and 18, right?
Correct. That virus is the main causative agent. But it's not the only factor at play. The guidelines also list a high lifetime number of sexual partners, smoking, HIV, and generalized immunosuppression as major risk factors.
But they don't just act independently, do they?
What's fascinating here is how the biology gets really intricate. Those other risk factors like smoking or having HIV don't just act as independent hazards that stack on top of each other.
Okay, so what do?
They actively modulate the host's immune response. Take smoking, for instance.
Right. We all know smoking is bad.
Sure, but in this specific context, the toxins from cigarette smoke actually inhibit immune surveillance in your mucosal tissues. They essentially paralyze the local immune cells.
Oh, wow. So the immune system just It just stops watching that area.
Essentially, yes. So, if a patient has a persistent HPV infection, smoking creates a suppressed microenvironment that provides a safe harbor for the virus.
A safe harbor.
Yeah, it allows the virus to thrive, hide out for years, and eventually trigger the cellular mutations that lead to malignancy.
That is wild. So because of that delayed diagnosis, because everyone blames the hemorrhoids while the virus just quietly does its work, doctors are usually looking at a tumor that has had plenty of time to grow.
Unfortunately, yes.
So before they can even think about treatment, they have to figure out exactly whose territory the cancer has invaded. They have to map the battlefield.
Precisely. And the way we stage this cancer has undergone a complete technological revolution.
Because historically, doctors relied heavily on clinical assessment,
Yeah.
right?
That
Yeah.
essentially meant using a physical examination to feel the tumor, estimate its size, and determine the staging based on that.
Which sounds terrifyingly imprecise when you're dealing with vital organs.
It was definitely limiting.
Mm.
But today, the gold standard has completely shifted. The guidelines dictate the use of high-resolution T2-weighted MRI.
And the level of detail they are extracting from these scans is absolutely staggering. They aren't just looking for a lump.
No, not at all. The MRI maps the exact millimeter-by-millimeter relationship of the tumor to the internal and external sphincter muscles.
They're even identifying specific sacral segment levels in the spine to help radiologists plan the exact angles for future radiotherapy.
It's incredibly precise. They even use a physical ruler on the skin during assessment.
Wait, really? A physical ruler?
Yeah, because if a tumor is located completely outside a 5-centimeter radius from the anal orifice, it's categorized entirely differently.
It becomes skin cancer, not anal cancer.
Exactly. That 5-centimeter rule is a great example of how highly specialized the tissues are in this region of the body.
Right, so it's like upgrading from a blurry 1980s Polaroid to a 4K 3D topographic map.
That's spot on. The moment you cross that invisible 5-centimeter border, the lymphatic drainage pathways change, the primary cell types change, and the entire treatment protocol has to pivot.
Which makes the MRI so crucial.
Yeah, it allows the multidisciplinary tumor board to see exactly which anatomical borders the cancer has breached.
Okay, but wait, hold on. If we have this incredible 4K high-res MRI that can map tissue down to the millimeter, why do the guidelines explicitly warn that predicting whether the cancer has spread to the lymph nodes is, quote, notoriously difficult? Shouldn't this hyper-advanced scan just light up the cancer cells in the lymph nodes?
That is one of the most frustrating challenges in oncology imaging. The issue isn't the camera, it's the subject.
What do you mean?
Well, lymph nodes are highly reactive little filtering organs. Whenever they detect any kind of inflammation, even a completely benign localized infection, they swell up with immune cells.
Oh, I see.
So on an MRI, a perfectly benign reactive lymph node can look absolutely identical in size and shape to a malignant lymph node that is packed with cancer cells.
So the map is perfect, but the enemy is wearing camouflage.
Exactly. Radiologists can't just look for an enlarged node anymore. They have to look for highly subtle structural clues inside the node itself.
Like what?
They are scanning for something called a mixed signal intensity, which indicates the tissue inside is heterogeneous and possibly necrotic.
Oh,
Or they look for an actual physical breach where the tumor has grown through the outer capsule of the lymph node.
and if they don't see those specific clues,
Then the imaging alone isn't enough. They often have to rely on an ultrasound-guided fine needle aspiration.
actually going in and pulling cells out.
Right, looking at them under a microscope to be absolutely certain the cancer has spread.
Okay, so once the multidisciplinary team has their 3D map, and they know exactly where the tumor is and whether the lymph nodes are involved, human instinct would dictate that the next step is obvious.
Get the patient into an operating room.
Right, cut the tumor out. But the guidelines reveal a massive plot twist.
It really is a profound philosophical shift in how we approach the disease. The primary aim, stated in the ESMO guidelines, is not just to eradicate the cancer.
There's a dual mandate.
Yes, the mandate is to achieve local regional control while simultaneously preserving anal function.
Because in the past, the standard procedure was brutal. It was something called radical abdominoperineal excision, or APE.
And surgeons essentially removed the entire anatomical area, which left the patient with a permanent colostomy bag.
But that approach has been officially demoted. Chemoradiotherapy, or CRT, is now the primary standard of care.
Correct. Surgery is mostly relegated to a salvage option, only used if the CRT fails to do the job.
And we really need to understand how the CRT works, because it's an incredibly sophisticated biological one-two punch.
It really is. The gold standard involved combining systemic chemotherapy with localized radiation. The chemotherapy usually consists of 5-fluorouracil.
Or a pill form called capecitabine, right?
Exactly. And that's mixed with a drug called mitomycin C.
So how are those drugs actually melting the tumor without surgery?
Well, 5-fluorouracil acts a lot like a molecular Trojan horse. It masquerades as a normal building block for DNA.
Okay.
Fast-growing cancer cells are constantly trying to replicate, so they greedily absorb this drug. But when they try to use it to build new DNA, the sequence fails, and the cancer cell basically destroys itself from the inside out.
Wow. And the mitomycin C.
That works by physically cross-linking the strands of DNA so they can't pull apart to divide.
So the chemo is essentially poisoning the tumor's ability to replicate.
Yes, and importantly, it makes the cancer cells highly sensitive to the second part of the treatment, the radiation.
But they aren't just blasting the area anymore.
No, the guidelines emphasize techniques like IMRT, which stands for Intensity Modulated Radiation Therapy, or VMAT, Volumetric Modulated Arc Therapy.
Which means what, practically speaking?
It means using computer-controlled linear accelerators to deliver precise, 3D sculpted doses of radiation.
Yeah.
The machine rotates around the patient, modulating the intensity of the beam to essentially paint the tumor with lethal radiation.
While drastically dropping the dose to spare the healthy bowel and bladder tissue situated just millimeters away.
Exactly,
Yeah.
just millimeters.
It's phenomenal. But here's where it gets really interesting. The timeline for this high-tech treatment is where the guidelines truly test human endurance.
Yeah, the waiting period is tough.
Once you finish this grueling regimen of CRT, the optimum time point to assess if the treatment actually worked is a massive 26 weeks post-treatment.
Yeah.
26 weeks. That is half a year of waiting, hoping the tumor is gone. Why not just do a biopsy at 8 weeks to give the patient some peace of mind?
It asks an immense amount of psychological resilience from the patient. I mean, it's agonizing. But the physiological reason for that delay is absolutely critical.
Why?
Squamous cell carcinomas of the anus regress very, very slowly. If a doctor goes in and does a biopsy too early, say around the 8 to 12-week mark, the guidelines strictly warn against it.
Because the treatment itself makes the tissue look suspicious.
Precisely. The targeted radiation and the chemotherapy cause intense local inflammation, tissue death, and severe scarring.
Right.
Under a microscope, those treatment-related effects can perfectly mimic active disease. If you biopsy at 8 weeks, the pathologist might see what looks like viable cancer cells and declare the CRT a failure.
Oh, man. And then the patient gets sent to salvage surgery.
Yes. They would undergo that life-altering radical excision, losing their sphincter permanently, all because of a false positive.
That is terrifying.
But if the clinical team exercises restraint and simply waits the full 6 months, the inflammation naturally subsides, the slow-dying cancer cells are finally cleared out by the immune system, and in the vast majority of cases, the patient is completely cured with their anatomy and function fully intact.
Patience is literally saving organs.
It is.
Wow. But we do have to talk about the reality when the waiting doesn't end in a cure. Because while CRT works wonders locally, about 10 to 20% of patients will unfortunately see the cancer spread or metastasize.
To distant organs like the liver or the lungs.
Right. And at that point, localized radiation can't save you. You have to pivot to systemic warfare.
And this brings us to a major recent breakthrough in the guidelines, the INTER-ACT trial.
Yes.
This trial established a brand new standard of care for advanced metastatic disease.
The INTER-ACT trial tested a new chemotherapy combination, carboplatin paired with paclitaxel. And the results were striking. It bumped overall survival up to 20 months compared to just 12.3 months on the older standard treatment.
It's a significant leap in advanced oncology. Carboplatin shatters the cancer's DNA, while paclitaxel freezes the cellular scaffolding so the cell can't pull itself apart to divide.
It's a highly effective combination.
It is.
But the most mind-bending part of this entire section on advanced disease isn't the chemotherapy. It's a biological paradox hiding right there in the data.
The HPV paradox.
Yes. Patients whose tumors are HPV positive or whose tumors overexpress a specific surrogate marker called P16 actually have better survival and progression-free outcomes than patients whose tumors are HPV negative.
It's totally counterintuitive.
The virus that caused the cancer in the first place is somehow helping the patient survive it.
It is one of the most fascinating phenomena in modern virology and oncology.
It's like a burglar breaking into a house, but in the process, they inadvertently set off a massive alarm system that locks them inside and calls the SWAT team.
That's exactly it.
The viral presence acts as a blaring alarm, right? Forcing the body's immune system to swarm a tumor that it might have otherwise completely ignored.
That is the perfect way to visualize the mechanism. This raises an important question about how the immune system interacts with tumors. When the human papillomavirus infects these cells, it produces specific viral proteins known as E6 and E7.
Okay.
In the HPV-positive tumors, those foreign viral proteins are highly visible to the host's immune system. They act as a massive red flag. This triggers the recruitment of something called tumor-infiltrating lymphocytes, or TLs.
The SWAT team.
Exactly, the SWAT team. These are the body's own specialized immune cells rushing into the tumor microenvironment.
Because the tumor has this bright viral fingerprint.
Right, the immune system recognizes it as foreign and attacks it much more aggressively than it would a spontaneous non-viral cancer mutation.
And the presence of that surrogate marker you mentioned, P16.
That is basically the biochemical proof that the virus is actively driving the cell cycle, which tells doctors this immune-vulnerable environment exists.
And that quirk of biology has completely opened the door for immunotherapy. The guidelines highlight drugs like pembrolizumab and nivolumab.
Yes, and these are showing really promising response rates around 17 to 24%, even for heavily pre-treated patients who thought they had no options left.
And to understand why those drugs work, you really have to look at how tumors survive in the first place.
Right, because many tumors protect themselves by putting the brakes on the immune system.
They exploit checkpoint pathways.
Specifically, the PD-1 and PD-L1 pathways. They use them to essentially tell the immune T cells to power down and leave them alone.
But drugs like pembrolizumab are checkpoint inhibitors. They block that signal.
They cut the brakes.
They cut the brakes entirely.
Yes, they allow the immune system, which is already hyperstimulated by the HPV viral proteins, to unleash its full force against the cancer. We are selectively arming the patient's own immune system by leveraging the virus's own proteins against the tumor.
It's just brilliant. But even when that battle is won, whether that was a localized fight with CRT or a systemic one with immunotherapy, the patient still has to live with the aftermath. Beating the cancer is only part of the story. Living with the body that fought it is the next phase.
Survivorship is incredibly complex. The end of active treatment is never the end of the patient's journey.
The guidelines lay out a very intense protocol-driven scrutiny for follow-up. Patients need clinical exams every 3 to 6 months for the first 2 years, and then every 6 to 12 months up to 5 years.
But there is fantastic news hidden in that grueling schedule.
Relapses after 3 years are incredibly rare.
They happen in less than 1% of cases, so extended routine imaging beyond that 3-year mark isn't even recommended.
Which is a profound relief for patients who spend years living scan to scan, just holding their breath for the results.
Yes, but the survivorship section also forces us to confront a very difficult reality.
The physical toll. The pelvic radiation used to achieve that organ-saving cure often results in severe, permanent life changes.
It does.
We are talking about early menopause, the irreversible loss of fertility in both men and women, fecal incontinence, and severe sexual dysfunction. We've moved away from radical surgery specifically to save the patient's quality of life, but the radiation cure still drops a bomb on their most intimate bodily functions.
If we connect this to the bigger picture, it really illustrates the delicate tightrope modern oncologists are forced to walk.
Yeah.
Even with those incredible 3D sculpting technologies like IMRT and VMAT, they are dealing with some of the most densely packed, sensitive real estate in the human body.
It's all right there.
They're trying to thread a needle with a laser beam while the patient is breathing. They have to deliver enough radiation to successfully eradicate the squamous cell carcinoma while desperately trying to minimize the collateral damage to the bladder, the bowel, and the reproductive organs.
It's a huge ask.
The imaging helps, the computer algorithms help, but the risk of long-term tissue damage is never absolute zero.
It really grounds the entire discussion. I mean, the science is soaring, the survival rates are improving, but the human cost is still very real.
It is.
So to bring this all back to you listening right now, why should you care about a highly clinical ESMO guideline on a rare gastrointestinal tumor?
Because it's about more than just one disease.
Exactly, because this document is a masterclass in how medical science fundamentally evolves. It shows an entire global community learning to map the body with incredible precision, finding the clinical courage to wait longer before cutting, prioritizing the preservation of human function, and learning to weaponize the body's own viral immune responses.
It really represents a maturation of medicine. We are moving from blunt force to precision strategy.
So, what does this all mean? Well, it leads to one final fascinating thought. We've talked extensively about how 80 to 85% of this specific cancer is caused by the human papillomavirus.
Yeah.
And right now, global medical guidelines are finally pushing for widespread universal HPV vaccination programs for younger generations.
Which is huge.
Which leaves us with a truly profound possibility. Are we currently looking at the very last generation of patients who will ever need to undergo these grueling pelvic radiation treatments?
It's amazing to think about.
Will the cutting-edge ESMO guidelines of 2050 simply be a historical footnote because a childhood vaccine eradicated the disease entirely before it ever had a chance to start?
Is the ultimate hope of oncology. The greatest paradigm shift isn't just treating the disease better, it's rendering the treatment obsolete.
Something to mull over long after this audio stops playing. Thank you so much for taking the plunge into this deep dive with us. We'll see you next time.